Good morning, everyone. I'm Michelle Hirsch with the Office on Women's Health in the U.S. Department of Health and Human Services. I work in Region 5. We work with the 6 states of the Great Lakes. And on behalf of the Office of the Assistant Secretary and the Office on Women's Health, I'd like to welcome everyone here today in person in Columbus, as well as all of the people who will be joining us and viewing this presentation via archive. I want to thank the Ohio State University for your collaboration and so generously hosting today's event, as well as everything that we will be doing tomorrow. And I hope all of you will join in for the webcast tomorrow. Through the Affordable Care Act, millions of Americans gained private health insurance that guaranteed them access to preventive services. The Affordable Care Act makes women's health a priority in particular by expanding access to preventive services, and recognizes that women are more likely to need a variety of preventive health services, but may be less likely to be able to pay for them. As such, the Department of Health and Human Services adopted guidelines for women's preventive services. These guidelines allow 47 million women to gain access, guaranteed access, to additional services without paying more at the doctor's office, in addition to coverage for an annual Well Woman visit. This presentation today is one in a series in which we address 6 of the U.S. Preventive Services Task Force recommendations. And today we provide information that will help providers integrate these particular preventive services into their provider practice, with a particular focus on pregnant and newly delivered women. Today we are so fortunate to have Dr. Sheila Raja discuss the basic principles of trauma-informed care. We recognize that in order to effectively help a patient modify their behavior, clinicians must understand the role that that particular behavior plays in their lives. Not surprisingly, Dr. Raja has a very impressive and lengthy bio. As such, instead of taking time to review all of her many, many accomplishments, I refer you to her bio that is provided to you. I will say that Dr. Raja is a clinical psychologist and an assistant professor of dentistry and medicine at the University of Illinois in Chicago. She completed her internship and postdoc at the National Center for Post-Traumatic Stress Disorder and is the author of a book titled Overcoming Trauma and PTSD. She is also a frequent media contributor and sought-after speaker. Sheila is a true thought leader, and we are most fortunate to have her here with us today. It now gives me great pleasure to introduce Dr. Sheila Raja. Thank you.
Thank you. Thank you so much. It's wonderful to be here today in this wonderful venue and really kicking off this very important event. So why don't we start talking about what are the basic principles of trauma-informed care within a healthy pregnancy and what providers need to know. Okay, so our goals for the next 45 minutes or so are to talk about the prevalence of traumatic events, including sexual assault, domestic violence, elder abuse, and child abuse, to understand some very common physical, psychological, and social consequences associated with traumatic events, and then to outline the basics of what is trauma-informed care and what might it look like in medical settings, with particular attention to some challenges that pregnant and postpartum women might be experiencing. Okay, so what is trauma? Basically, mental health professionals take a look and say trauma is when a person has been exposed to something, either they experience it directly or they witness it, or someone that they love is either threatened with death or serious injury, basically that their bodily integrity has been violated in some way. And the person responds to that with helplessness or horror. So some common traumatic events are motor vehicle accidents, natural disasters, sexual assault, childhood sexual abuse, domestic violence, combat, elder abuse, homicide, suicide of a loved one. But there's also a practical definition of trauma. So when we go around day to day and try to figure out is something traumatic, we can think about it as, is this non-consensual? So first of all, the person, doesn't want that to happen to them. The victim feels discomfort or fear or feels intimidated in some way, or their bodily integrity or that of somebody else close to them is threatened, okay? So why do we care? Why do we want to focus on trauma? basically, unaddressed trauma in the United States affects all of us. And we hope in the next 45 minutes to show you that trauma actually has a large impact on the health and really the economy of our nation. So what's the prevalence of trauma in the United States? And we'll go over this very briefly today. But basically, let's start with child abuse, for example. You know, Child Protective Services investigates about 3 million cases a year involving 5.5 million children. We know that our youngest children are actually, sadly, the most vulnerable. And that almost a third of substantiated reports, those kids are less than 5 years old. Kids that are most likely killed in abusive situations are more likely younger children and special needs kids. When we talk to adults and we do large epidemiological surveys on childhood abuse, about 8% of adults report being physically abused as children. And a large percentage of the adult population talks about childhood sexual abuse as well, and that's men and women. So when we ask, again, in these large epidemiological surveys, when we look at the rates of adult sexual assault, we also have very high rates, sometimes as high as 22% of women talking about experiencing adult sexual assault. When we think about interpersonal violence, or sometimes called domestic violence, about a quarter of women in the United States are talking about at least once having a current or former boyfriend physically hurt them in some way. Now, when we think about pregnancy, this is a time when people are very, very vulnerable to abuse, because interpersonal violence in pregnancy is actually related to preterm birth and lower birth weight as well. So it also leaves a woman feeling very socially isolated often when this happens to her when she's pregnant. It may be more difficult to leave because she may be thinking about, does she want to try to keep the family together for the sake of this child? So this is a very high-risk time for women. It's hard to talk about trauma in the United States without talking a little bit about the role of gun violence and community violence. So when we look at women in violent relationships, they're 5 times as likely to be murdered if their partners own a gun. We also have an issue with firearm violence with our children. About 7,500 pediatric admissions for gunshot wounds every year, which is a lot compared to other industrialized nations. And firearms deaths in children in the United States, and including young people as well, is twice the rate of cancer, 5 times the rate of heart disease, and 15 times that of infection. So the role of firearms in both domestic situations and community violence is part of the picture of trauma in the United States. And then, you know, unfortunately, trauma affects even our most elderly. 6% of older folks talk about significant abuse in the last month, and often those perpetrators have prior criminal or domestic violence histories. So what are the short-term consequences of traumatic events? First of all, psychologically, we can think about when one of these types of events happens to you, people are often in disbelief. They feel numb, they feel shocked immediately afterwards, shame, guilt, self-blame, depending on the nature of what's happened to them. And of course, anxiety, sadness, anger, confusion, wondering about your safety, difficulty concentrating. And then physically, traumatic events take a toll on you. If you can think about it, often our appetite changes. Sleep, that's a huge one that I think that we should think about, because when your sleep is disrupted, in many ways, the way that you cope to deal with those sleep disruptions is going to be affected, and we'll talk about that in a second. And also even aches and pains in the body. Sometimes people somaticize what they're feeling. Difficulty trusting others, feeling socially isolated, missing work, missing classes, and then using drugs or alcohol sometimes as a way to cope, often with sleep difficulties or feelings of anxiety or feelings of sadness. What predicts recovery? So, you know, we've talked a lot about the prevalence of violence. We've talked a lot about, you know, what happens to you immediately afterwards. But we do know that there are a group of people that seem to be fairly resilient after they've experienced a traumatic event. And I think that healthcare providers really can learn a lot by taking a look at what predicts recovery, because that's what we want to be able to foster, right, in the long term. Well, First of all, we do know that having no prior trauma history is better. And that may seem self-evident at first, but sometimes providers have the misguided assumption that if you experience one traumatic event after the other, that you actually become used to it. And that's not the way that it works. Actually, the more traumatic things that we experience in our life, the more difficult it is for us to be able to bounce back over time. Of course, we know that people that have experienced a lot of social support and they have a good social network tend to do better. People that have a sense of life purpose. So if you're already active in your community, if you already are active and feel like you're giving back in some way, and you can go back to that after something difficult happens to you, you're more likely to recover from trauma. And there's a couple of specific ways of coping. Religious coping or a sense of spirituality really does seem to help people in the long term. And then what psychologists talk about in terms of approach versus avoidance. And what that means is when people break down into small steps what they've been avoiding, so trying to stay involved in what's going on in their life, so that's approach, as opposed to avoidance. We do know that in the long term, when people avoid what they're afraid of or threatening kinds of or upsetting situations, their life becomes smaller and smaller and more limited over time. So whatever providers and even their social network can do to encourage them to stay involved is very important in terms of predicting recovery. Okay, so in the long term, what kinds of consequences does trauma have when it goes untreated? We do know that there are not only psychological effects, but physical and neuropsychological effects on the body long term. Particularly when people experience stress that's early in their life and repeated over time, what we call toxic stress. And that kind of toxic stress actually leads to a higher level of physiological arousal, more stress hormones in the body. It actually affects the way that our emotion regulation circuits work. And that impact is actually long-lasting. So it can lead to, of course, things like depression, post-traumatic stress disorder, anxiety disorders, things like substance abuse. But trauma also takes a toll not only on our mental health, but our physical health. So a very important study, and it has a wonderful website, so if you're not familiar with it, please do look up the Adverse Childhood Experiences, or the ACE study. Is a really very interesting and very large study, very comprehensive, that was done to take a look at the role of traumatic events and how they interplay with physical health issues later on in life. So in this study, they took a look at 17,000 HMO patients, Kaiser Permanente patients, who were participating in a routine health screening. And what they found with these patients is that they were a largely middle-class sample. They all had health insurance. But they found that the health, social, and economic risks that came out of childhood trauma were quite profound. So what is defined as an adverse childhood event in this study? So here's how they define this. And this is based on any of these things happening to you prior to the age of 18. Recurrent emotional abuse, recurrent physical abuse, recurrent sexual abuse, neglect, lack of emotional support in your home, parental separation or divorce, violence towards your mother, a family member who abused alcohol, living with someone who was depressed, mentally ill, or suicidal, and having an incarcerated family member. So you got 1 point on the ACE study for having any one of these things happen to you. So if you can see, you can get a range of points. Okay? So you get 1 point for any one of these things happening to you ever. So what's interesting about the results here is there's about 1/3 of the population that are extremely fortunate and didn't have any of those things, if we go back, didn't have any of those things happen to them, about 1/3 of the population. Now, if you look, though, unfortunately, having at least one of those things happen to you is fairly common. And if we look at folks that have experienced an ACE score of 4 or 5, if you concentrate on that percentage of 5 or more, which is about 10% of the population, a little bit more than 10% of the patients that they surveyed, they found that actually that's more likely to be women in that group. And they really found a very strong and graded relationship between experiencing these adverse childhood events and then the adoption of health risk behaviors, so things like smoking, overeating, substance abuse. And then, of course, it would make sense that when you are adopting those types of health risk behaviors, it leads to a greater disease burden and sometimes even early death. So if you think about that percentage of the population that were about 10% that experienced an ACE score of 5 or more, compared to folks that have that 1/3 of the sample that had nothing traumatic happen to them, the people with an ACE score of more than 4 had higher odds of, and these are just some examples from the ACE study. It's very, very rich in terms of the descriptions of and the information it provides, so it's definitely worth looking up. But basically, you have a much higher odds of having a sexually transmitted infection. You're more likely to have COPD, that's probably via smoking. 460% more likely to be suffering from depression. If you're a male with an ACE score of more than 6, you're 4,600% more likely to be an IV drug user. So again, these are just a few statistics from the ACE study. And what they found is that an increase in adverse childhood events are associated with various health problems, including autoimmune diseases, COPD, frequent headaches, heart disease, liver disease, lung disease. So it's a very, very strong and powerful study. And when we take a look at the literature on the health effects of trauma across the board, we do find that traumatic events of all different sorts, not just childhood abuse, but also adult abuse, are associated with obesity, substance abuse, smoking, high-risk sexual behavior, which then translates into things like chronic pain, GI disorders, gynecological problems, fibromyalgia. And again, we know that multiple traumas have more physical health consequences. So people don't get used to experiencing traumatic events. They don't desensitize to traumatic events. So it's important for us to address traumatic events and get people help and treat them and acknowledge them rather than let the cycle of violence continue. We also know that traumatic events have take a toll not only on our psychology, but our biology. And that over time, there's actually neuroendocrine differences when survivors and non-survivors deal with stress. So long term, we actually see physical and physiological changes. So when we look across the literature, we find that survivors of traumatic events have a higher utilization of medical services. So what does that mean? Overall, they're going to the doctor for sick visits more often. And they're also reporting a greater number of physical health problems. They're saying, hey, I don't feel well, I feel sick. Particularly people who have full-blown post-traumatic stress disorder, okay? However, we see a paradox in the literature. We also see that trauma survivors are less likely to obtain regular mammograms, to go out and get regular cervical cancer screenings, and even to attend regular dental appointments. So what in the world is happening? I mean, on the one hand, survivors report numerous health-related issues, and they use a lot of medical care. But on the other hand, they're not always using preventive care. So we believe that there are probably a couple of different reasons that this is going on. Obviously, there might be some psychological reasons, right? On the one hand, if you think about the fact that you've been through something that's traumatic, really, it's pretty upsetting to have to go to the doctor or maybe the dentist, right? Because, you know, it's bringing up a lot of fears for you. You feel like, you know, your body, something bad has happened to your body in the past, but you're going to have to go and something's going to be done to your body. So it's kind of re-triggering in many ways of trauma. There also might be systemic reasons, things that we're doing in the healthcare system that maybe we could be doing better. So maybe there's something going on called secondary victimization. And let me talk to you about the definition of that. Secondary victimization is really the idea that when people come to us for help with an issue, as providers, we kind of have a choice. We can help them tie up that knot and make it as strong as possible where they're about to break, or we may do or we may say something inadvertently that kind of snips the last thread. So what does that mean? This term secondary victimization actually came out of the sexual assault literature. And it's also known as the word re-traumatization. And sometimes it's victimization that occurs not as a direct result of the trauma or the criminal act, but it's the responses of institutions and individuals to the victim. Okay, so what are some examples of secondary victimization? Secondary victimization is when we refuse to recognize an experience as criminal victimization. Now, we've moved a long way, for example, in the issue of marital rape. You don't often hear people use the word marital rape, and I think I looked it up. I don't have the exact date, but for example, in the state that I'm from in Illinois, marital rape wasn't considered a crime until, several decades ago. So that's where you could see that if that was happening to somebody and then a professional says, well, that's not really wrong, that can be extremely re-victimizing. I don't think that that stuff happens as much as it used to. I think we've made a lot of progress. There's also intrusive or inappropriate conduct and victim blaming. And then the last category of secondary victimization is medical processes that don't always include the patient's perspective on what's going on. That's the area in healthcare, and I'm going to give you some examples, where I think we have a lot of work to do to use the patient's perspective, and especially a potentially traumatized patient's perspective. So what might this secondary victimization look like in various settings? Well, you can think about it, for example, in the emergency room. If you're a survivor of domestic violence or sexual assault, the amount of time you have to wait. And of course, sometimes we can't do anything about that within the way that our healthcare system is set up. But that can be re-traumatizing. Often, we have very disjointed services, and we'll have survivors tell us it's very difficult to tell the same story again and again, from the front desk staff to the nurse to then the physician. That can be very re-triggering sometimes. In primary care, sometimes a woman might disclose domestic violence and a very well-meaning provider might say something like, you need to leave this guy, you need to leave this situation right now. Again, not understanding that women are most likely to be murdered at the time that they're trying to leave a domestic violence situation. So to me, that's not a provider that means to hurt a woman or do something traumatizing. They may need more education about the dynamics of traumatic events. Often in healthcare, we skip to reassurance. When someone discloses something to us, we'll say, it's okay, you need to move on with your life, everything will be fine. And sometimes survivors report in various studies that they can hear that as, you know what, you don't want to hear what I've been through. You don't want me to talk about this. And so we need to make sure that we balance reassuring patients with also good assessment about what's gone on and what's happening. But again, that takes time, and that's difficult with some of the constraints that we face in the healthcare system. Survivors talk about within surgical procedures, if you have been the victim of something traumatic and you're going to be sedated or you're going to go under anesthesia, it's very difficult to have people have access to your body. You don't often know who's going to be in the room, and it's sometimes the whole team introduces themselves ahead of time, but sometimes in healthcare that doesn't happen. Dental settings. This is an area that I think we're learning more and more about, and how re-triggering this can be for survivors of traumatic events, because you're laying back in the chair, you're in the supine position, you have a dental dam or something else in your mouth and you can't talk. Depending on the kind of abuse that you might have suffered or things that you might have gone through in your life, that can be extremely anxiety-provoking and very difficult for people. In psychiatric settings, the use of restraints, invasive searches. So there's a lot of points in the healthcare system where we have the ability to think about the perspectives of survivors and to really improve what we're doing. So when we talk about the event that we're kicking off here today, how do the needs of pregnant and postpartum trauma survivors fit into this picture? And the answer to that is actually remarkably consistently, unfortunately. When we look at work, for example, that's been done with women with childhood sexual abuse histories, and they talk about what concerns them about prenatal care, often they talk about experiencing more discomfort in pregnancy than women who have not survived traumatic events. So again, that whole picture of when you've survived something traumatic, your physical health suffers. Women talk about experiencing more abuse sometimes during pregnancy. So again, it's a very high-risk time. Often, these women who've been traumatized or experiencing childhood sexual abuse talk about more non-scheduled medical contacts. So meaning, again, more medical concerns, more sick visits, more ultrasounds, particularly during first pregnancies. And this is all from a very large review of the literature on pregnant women, so it's a very helpful review if those of you who are particularly interested in this topic. When we ask people after the baby's born, what concerns do you have? Childhood sexual abuse survivors talk about increased rates of depression, so they're more vulnerable to depression. They're often, they fear being re-triggered during routine standard exams. They also talk about the difficulty in relaxing. So before the baby is born, they talk about, well, you know, you've told me to take these childbirth classes, but I'm supposed to go and close my eyes in a room full of strangers. These are small things that sometimes we don't think about in the healthcare system of how if you've been traumatized or depending on what you've been through in your life, these can be very difficult things. And this could be something that's just standard of care that we don't think about. This is why maybe women aren't engaging in this, or certain, you know, people that have been through certain types of things. So postpartum, women talk about childhood sexual abuse memories resurfacing during labor. They overall, across studies, seem to experience higher levels of subjective pain during delivery. Again, postpartum depression is higher. So depression during pregnancy is higher, and postpartum depression is also higher. There is a trend towards women with child abuse histories talking about a higher intent to want to breastfeed, interestingly, to want to take care of their children. And then there's some literature suggesting that some of these women actually may have more difficulty in breastfeeding. So they may need more support and more help to be able to do it. So let's try to put this whole picture together and talk about what does this mean in terms of trauma-informed care. So clearly, we have lots of different points in our healthcare system where we can do better to serve the needs of survivors of violence and trauma. So what is trauma-informed care? So the National Center for Trauma-Informed Care offers this definition, that every part of an agency or institution, from the front desk staff, administrators, care providers, so everybody, basically everybody, understands the effects of traumatic events, sensitively interacts with trauma survivors, avoids re-traumatization, and engages in screening and prevention as appropriate. So I have the word as appropriate underlined there because I think that often when we think of trauma-informed care in medical settings, we immediately think about, well, we need to screen people for violence and we need to screen people for trauma. And absolutely, we may, depending on the setting, but what we want to present to you today is the idea that that may be one facet of trauma-informed care. So what does that mean in healthcare settings? How do we operationalize such a large definition, such a lofty goal, an admirable goal, but a very tough goal? What does that mean for an individual provider or an individual hospital, an individual clinic? So you can look at this, the trauma-informed care pyramid, as sort of a framework to start thinking about what is trauma-informed care in health settings. So we'll go through each one of these levels of this pyramid. At the bottom, we have patient-centered communication skills, okay? So patient-centered communication skills can be behavioral or communication skills. And again, this doesn't require knowing a patient's trauma history. This is something you would do with every patient every time. So what can we do with every patient every time? First of all, providers can ask patients, what can I do to make you more comfortable? If a patient seems worried about a procedure, you can ask them what's helped them with that procedure in the past or a stressful situation in the past. You can use tell, show, do modeling, which is basically letting them know in advance what to expect for the whole appointment, because often trauma survivors report that feeling out of control during procedures is one of the things that worries them and maybe holds them back from engaging in preventative care. Letting a patient know that they can raise their hand or they can do something to let you know if they're in discomfort. So again, these aren't difficult things to do. They're pretty easy, simple things to be able to incorporate into everyday practice with every patient. Again, asking patients, what can I do to make you more comfortable? Before we proceed, is there anything you think I should know? You know, just to let you know, this is the way the appointment generally runs. So to give an overview of an appointment is very important. Okay, so if we back up for a second, the next part of the pyramid here is understanding the health effects of trauma, okay? So understanding the health effects of trauma, again, I want to point out, does not involve delving into an individual patient's trauma history. You don't need to know whether they've been traumatized or what they've been through. It's really an understanding on the part of providers that trauma has health-related effects. We have so much research now that suggests that many coping behaviors, when people have been traumatized, they may engage in smoking, drinking, even high intake of sugary foods, sugary drinks, high-risk sexual behavior. All of those things are not necessarily related to stressful life experiences, but they might be. And so, it's consistent with a lot of other things. If people are interested in things like motivational interviewing, where again, you approach the patient and do it in a very collaborative manner rather than, this is what you need to do and you should stop smoking. So it's a much more collaborative, understanding way of approaching the patient. Okay, so the next level of the pyramid talks about understanding your professional role and really creating collaboration with other disciplines, with other professions. So maintaining a list of referral sources for patients who do disclose spontaneously a trauma history in your practice. So do you know somebody else who may be a good social worker that may be able to handle a patient that is going through a difficult time? Do you know a good specialist in various medical fields that you think is very sensitive and very gentle? So that's part of trauma-informed care too, is knowing who to refer patients to. Another part might also be keeping information readily available in your waiting room. So again, the National Center for Trauma-Informed Care has a good website where you can refer to some more information. Having local referral sources. So again, these things can be provided with every patient every time. The other thing, sometimes I will add a slide up here, which I don't have today, which says, stick to your job description. And not in a bad way of like, oh, that's not a part of my job, but really that the role in healthcare is to go ahead and treat the patient and provide healthcare. It's not to try to get to the bottom of, did this happen, did it not happen, what is the nature of the circumstances. Again, law enforcement gets to do their job, mental health gets to do their job, and physicians get to do their job, nursing gets to do their job, and when we all do our jobs and we do them well, we can actually do really right by the patient. And I think sometimes providers tend to get themselves worried that they're going to have to investigate and figure out whether something actually happened or not. But if they stick to their domain of expertise, they can actually do very, very well by a patient. Another part of this collaboration and understanding our professional role is understanding our own mandated reporting requirements and informing patients when confidentiality needs to be breached. So, you know, again, there's nothing worse than telling a patient everything that we talk about is confidential, but then they disclose some sort of trauma that might be ongoing, and then you feel like, you know, legally you're a mandated reporter and you need to disclose that abuse to authorities. So again, talking about that up front with patients, every patient, every time, is very, very important. Now, the flip side of that is we also need to respect the wishes of survivors to report or not report abuse when mandated reporting isn't required. So there's a lot of studies that talk about how healthcare providers are uncomfortable with mandated reporting. They're uncomfortable with understanding when they're supposed to report, when they're not supposed to report. Part of good trauma-informed care initiatives has to include developing a comfort with that, but also developing a comfort with letting survivors drive those reporting decisions when it's not mandated. In some states, for example, domestic violence doesn't need to be reported. In some states, it does. So it's really important for providers to know. So through many years of doing this training, we have added also to the pyramid this idea, as we move up the pyramid, of providers understanding their own history. All of us are human beings, and we bring to the table things that we've experienced in our own lives. And we have often had providers come up to us after these trainings and say something like, you know what, a provider saying something like, I'm also a survivor of abuse. How do I handle this? What do I do if a patient opens up to me and, you know, I'm not a therapist. I don't know what to do. I don't know how to handle this in, you know, my daily practice. And that's a very valid and legitimate question. I think the first part of it is understanding that your own history might interfere with your ability to ask questions or be empathic to a survivor. You may feel like you're either shying away from an issue, or you may feel like, you know, once that opens up, you're not going to know how to set boundaries around that issue. So it's very important to remember you probably don't need to delve deeply into the person's trauma history. Again, it's the stick to your job description, but in a competent, empathic, sensitive way. So learning communication techniques that are empathic but also present focused. I think that healthcare providers can say things like, you know, I'm not the expert on this, but I have referrals. Or I'm so glad that you told me that this is going on with you. What can I do to make you more comfortable at today's appointment? Again, validating that the person has opened up to you, but at the same time, you know, not taking on the role of being their therapist. But remember that part of the trauma-informed care pyramid involves having good referral sources that you can send that person to as well. So most of this trauma-informed care pyramid that we're talking to you about here doesn't require screening, asking, or delving deeply into the person's trauma history. Just what we're calling universal trauma precautions. You can use the analogy of sometimes when we think about HIV. And in the 1980s, prior to everyone wearing gloves, thinking, well, anyone might be HIV positive, physicians used to try to do some screening and think, are people in the high-risk groups? Is this person at risk? Is that person at risk? And then at some point, healthcare made the larger decision and said, you know what? Everybody might be HIV positive. And I would suggest that that is really what we need to do around the issue of trauma. I mean, we've shown you so much data here about various types of traumatic events and how impacted people are across communities and across the lifespan. So really, anybody sitting in your office might be a survivor of traumatic events. And so universal trauma precautions really involve treating every patient like they may have been traumatized. And so all of these strategies that we've talked about to this point really can apply to every single patient every time. And ideally, they're things that don't take a lot of time in the appointment. Okay. However, there are certain settings where screening for trauma might be appropriate. Perhaps you work in a very high-risk setting where you think there is a lot of trauma and we need to identify it. It may also be dependent on your specialty. When we have surveyed women about do you want your physicians and your healthcare providers to ask you about your trauma history? They'll often say it depends on the specialty. They may say something like, well, I don't know if I want my dermatologist to ask me that, but I'm okay with my pediatrician to ask me. I'm okay with my obstetrician, my ER physician, my regular internal medicine or family medicine doctor. So in those specialties, it may always be appropriate to screen for traumatic events. And of course, if you see acute injuries that you think are consistent with some kind of traumatic event, you should be asking about traumatic events. There is, unfortunately, data that suggests that sometimes healthcare providers may see those things and not screen for trauma. Again, out of fear of what am I going to do if the person does disclose a trauma history to me? And we're hoping that by giving you this framework of the trauma-informed care pyramid, that will lessen some of the anxiety of what if somebody really does disclose a history to me. Well, then you have good referral sources for them, you have some good communication skills that you can use, and various other tools of how you can help that patient get through that situation. If you decide to screen for traumatic events in your practice, in your clinic, in your hospital, it's really important to consider two questions. One, how will positive screens be handled, right? You can't just start screening for traumatic events and then have nowhere to send people or no infrastructure. The other thing is there an opportunity for people to practice handling what we call a positive screen? So the first time you handle something where someone says, yes, actually my husband is, abusing me, you don't actually want to be in the room with a patient the first time that that's happened. You really would like to ideally practice some of these situations ahead of time and get your staff, even your front desk staff, comfortable with handling those situations, ideally through some type of practice situation. Okay. There are a couple of websites that are very helpful if you are interested in the specifics of screening in healthcare environments. Health Cares About IPV, which is about interpersonal violence, contains a list to an exhaustive CDC document on various screening tools. And the National Child Traumatic Stress Network also has some very excellent resources on screening. So a very brief summary of today's talk is that traumatic events are highly prevalent in our culture, that trauma has negative physical and emotional consequences, that survivors sometimes experience what we call secondary victimization or secondary trauma when they seek help from formal systems, and that we all as providers can help reduce some of those long-term issues through trauma-informed care practices. How do we get people to engage in the healthcare system so they're engaging in preventive care and not just using sick visits is really the bottom line for some of this. An even briefer summary is really by getting someone into care, you might save a life, indirectly or directly. So directly meaning you might get them out of a very difficult, frightening situation. You may also link them to care, and then the ways that they're coping might change, and then that may improve their physical health. So we also know that it's not just the immediate violence, but it's the long-term effects of trauma that take a toll on people's physical health. So engaging them in the healthcare system is really, really important. A final thought is that sometimes when we see things and we think, wow, there's nothing beautiful that can come up, we can see some amazing things. And so I think that one of the things for those of us who are specialists in trauma and post-traumatic stress, you really do meet individuals and they really reaffirm your faith in, if we can do things that foster resilience and recovery, the most amazing things can happen in people's lives. And I think that's something that we need to continually remind ourselves of. So a few acknowledgments. Thank you to Michelle Hirsch from the Office on Women's Health and Dr. Mamouna Hasnain, who is a colleague of mine at the University of Illinois at Chicago, and several research assistants, and of course many patients through the years who've helped shape these ideas.